Now, the last block of studies was SGLT2 inhibitors, so we've heard a lot about SGLT2 inhibitors. At the meeting, there were two that had more data coming out. One was DECLARE and the other one was CREDENCE. So the DECLARE study, just to remind people, that was presented at the American Heart. Previously, 17,160 patients, average follow-up 4.2 years, also a long study. And so the specialty of that study, or the key feature of that one, was 60% primary prevention patients in there, so a lot like what our practice would look like, and then 40% was secondary prevention. So the main results had come up, and maybe what I'll do is I'll ask David just to remind us of the main results, and also at the ADA they presented some renal data as well.
Yeah, so the DECLARE, as you say, was the American Heart Association last year, and we did touch on that briefly when we got together in April. But the key result from DECLARE was in this very primary prevention population, it didn't show a reduction in that 3-point MACE, predominantly because the 3-point MACE events were so few and far between. What it did show a reduction is in heart failure. And that seems to have been a common theme that's gone through all of those SGLT2 inhibitor trials, that it seemed to reduce both incident and heart failure hospitalizations in the secondary prevention and also in the primary prevention population. So it does seem to give some role in the patients with heart failure. But what's always been interesting with the SGLT2 inhibitors, and when they first came out, there was always the worry that this is a drug that is effectively another diuretic. And it's going to put more sugar into the bladder, and it is working on the kidneys. And we know that the kidneys of people with diabetes are particularly sensitive. We know that the people with diabetes are more prone to acute kidney injuries and chronic kidney disease. So there's always been this caution that are SGLT2 inhibitors going to make CKD worse? And the CKD results from the DAPA study are actually really positive. We see a reduction in chronic kidney disease. We see a reduction in acute kidney injuries. And this is not just in the secondary prevention population. This is also in our primary prevention population. So for the first time, we know we have drugs that can reduce chronic kidney disease along that whole spectrum. And that starts to raise the possibility about whether these drugs are having all of their effect through sugar, or whether they're going to have additional effects beyond just the sugar and weight loss effect that you see from SGLT2s.
Okay, great. So because I think we were concerned there used to be the eGFR cutoffs, which there still are, but that was because the sugar doesn't go out of your kidneys, so your A1C doesn't come down enough. So the agency said, all the regulatory agencies around said if you're not lowering A1C, then below 45 eGFR, that might not be useful. But what David's alluding to is that there's a flow benefit as well. Just like, remember ACEs, they have blood pressure lowering and things like that, but they also have flow benefits in your kidneys, so that's why we use them now in chronic kidney disease and so on and so forth. And so the same thing is happening with the SGLT2 inhibitors, and that's what was presented with the DAPA.
Yeah. And interestingly, the way that they work is we know that although the kidneys aren't filtering as well in a person with diabetes, every individual nephron is actually working harder. So every individual nephron works harder in order to adapt for the fact that we've lost 20% of our kidney function. And so what these do is make every single nephron that's working harder just that little bit life easier. So as a result, we do see an immediate dip in the kidney function. When we start these drugs, the kidney function does drop in exactly the same way as the ACE inhibitors drop when you first stop it. But that's making every single nephron's job easier, and therefore every nephron will continue to live just that little bit longer, which means it has a longer term protective effect.
Good. And the one key feature about the DECLARE study was that the entry criteria, the eGFR, had to be above 60. And so therefore the average eGFR was 85. So pretty much these were normal-ish kidneys. People on the dapagliflozin arm maintained, and then the placebo arm or the people usual care deteriorated. So in other words, in normal-ish kidneys, we can have some benefit as well.